That means that as long as Jo's turned the pens on, I'm sure she's doing that now, that you will be able to write a dot on that line. And this first question is a little poll to start with about how much do you feel you know about care home vanguards, with 1 being I know very little and 10 I know a lot. If you wouldn't mind taking a minute now to put your dots there so we can see the range. Doesn't have to be a dot. Look, some of you are getting creative there. Don't feel limited by the dot instruction. Any old shape is great. And this also gets you a chance to use some of the great tools that we've got on the digital discussion. So wait just a minute more to see if any people are reflecting. But it's looking like quite a good range, with most people kind of middle to knowing a reasonable amount. Okay, great. We'll close the poll now. And keep onto your pens, because if you would, have a look at the circles and see which is the one that most applies to you. One thing is that for many of us, we may have family and friends who are living in care homes. So if that applies to you as well as another category, would you mind choosing that so that we can see who's got personal lived experience? The categories, as you can see, is that you work in a care home, you're part of a vanguard in the new care models, you're considering developing a new care model, or you're an improvement organisation such as an AHN, a clinical network, or several others, or you're just interested and you work in the health and care system. Okay, so again, quite a mix, but lots of people involved in vanguards already, a number from improvement organisations, and a number interested in learning more, and slightly fewer residents, families, and friends. Okay, next slide, thank you. And then if you could just put a dot for where in the country are you? Okay, any more for this poll? Great. So a good range there too. So in the discussion session that follows William's session, some of the things just to be thinking about is just thinking a bit more about the enhanced health and care homes model. We're going to see an outline of the framework and hear a perspective from NHS England and the New Care Models team as well. So as you all know, there are 6 enhanced health in care home vanguards. We've got 4 of them on the discussion today. And the framework, which I'm sure you'll have seen before, has these 7 different elements. We won't go through them in detail, but it's just important, I think, to have those in your mind as we're having the conversation. Okay, fantastic. So we'll hand over now to William Roberts, who's going to tell you a bit more about it. Just a reminder, do ask your questions in the chat box, because those are the ones that we'll put to the panellists. Thank you. Over to William now.
Hi there. Can everybody hear me? Tara?
Can do, yes.
Yeah, brilliant. Thank you everybody for joining this afternoon. It's nice to have you all on this session. I guess To set the scene today, we've got an opportunity, I think, to have a discussion with a range of people, and I think it's particularly good that it's not just people who are working in the vanguards, but also some of the people who've been working with us as well from other parts of the country and other parts of the system. I won't say a great deal except to say this work really is different because it gives us a huge opportunity to do a couple of things. Firstly, to really look at how the NHS can better work with the excellent social care services we already have. Secondly, to really think about how we deliver better care for those who can no longer live independently at home. And then finally, also, how can we bring together health and social care to work together to deliver seamless services for the people that we serve. So I won't say a great deal more, but if there's any questions people want to ask before we get into the rest of the session, please do. So Tara, anything you'd like to ask me or anything that people have already asked or on the questions?
So what are some of the things that have struck you? Because I know you've visited all the care home vanguards, haven't you? What are some of the things that you've struck that you think would be great to be out there in many more care homes?
So I think there's a couple of general things and a couple of specific things. I think the first thing I would say is that, you know, I've not just visited lots of care home vanguards, but I've visited lots of places over the last 12 months, and there are some amazing things going on out there. And lots of places have something they can build on. So even if you're out there and you think, we're not really geared up to do this, we've not really done anything in this area yet, I can guarantee you that somewhere in your area there will be something that's being done that is amazing, that you can use, you can build on, or something that you can start with as your starting point. What's different about the care home vanguards, I guess, is that they're trying to do all of it at once. They're trying to do everything that we've described in the framework, rather than just doing pieces of it or one part of it, which I think is different. In terms of what do I think are the things that have been really amazing to me, what's different, I think the first thing I'd say is that we have a massively undervalued social care sector in this country. The NHS doesn't really understand what social care does, and I don't think people realise how innovative, high quality and complex some of the things that some of our care homes are delivering that exist in the system. So I think it's really important that people start to look at what's in their local area in terms of social care provision and really start to build relationships with them, and I think that's what some of the vanguards are doing really, really well. I think the other thing I would say is that each individual vanguard has got some amazing stuff, but when you go there, what you feel and what you see is real passion and energy of people coming together with a genuine shared purpose and shared vision about what they're trying to achieve. In terms of specifics, I think there's some really good stuff. I think if you go to Newcastle Gateshead, how they've brought together their teams through clinical teams to come together to really deliver an incredibly high quality, multidisciplinary team approach is amazing. We'll hear some of that later. I think if you go to Wakefield, how they've focused on holistic assessment, working with communities and really thinking about how they mobilise what's in their communities has been brilliant. When you go to Airedale, you realise it's more than just video conferencing and telehealth. It's about a brilliant clinical team being available 24/7 to care homes. If you go down to Sutton, something like the Red Bag, the poster they've done for Are You Concerned About Resident, really simple ideas that make a real difference that have been developed with the care home sector, really, rather than just the sector. Hello there, I think I'm about to go on to video as well, so you get to see me. So working with the sector rather than just working on their own in the NHS to develop those ideas. They've gone to sit down with the care homes, they've gone to sit down with the local authority and said, how do we all come together to do that? And then if you go to East North Hearts, the one thing I was really struck by there was that everybody talks about how they get care delivered. They don't talk about health and social care, it's about a care sector, and how they've brought together their providers through the Hearts Care Provider Alliance is really, really interesting. And the work they've done around bringing together providers to be part of that system and look at how they make the social care sector sustainable locally has been really impressive. And then finally, if you go to Nottingham, the work they've done on contracting, which again I think we'll hear about later, is really interesting, and it offers simple solutions, but it also offers something that builds sustainability into the system.
Okay, fantastic, and we're starting to get some comments in through the chat room. Leslie Bainbridge, you're around, aren't you? Have you got anything that you'd like to add about the Gateshead work?
Hi, I'm not sure if Leslie's joined. I'll just check for you.
She's listed. So just one of the questions that we do sometimes hear for William is, you know, it's all very well being a vanguard, they're so fortunate, they get investment, anything's possible. And what we know is that actually the care homes group, compared to some of the other vanguards, have managed to do this on less resources. But what would you say to care homes out there who are interested in CCGs, who are interested in doing some of this work without the benefit of extra investment?
So I think the first thing to start with is to really understand what's going on in your local area and what you've got out there. So we're developing a self-assessment tool to work with the framework to allow you to really understand what you've got already. A lot of the time people just don't realise all the things that are going on in that area. Even in my organisation, when I walk through the door, there's loads of brilliant work that's been going on, but it's how we make sure it's joined up and isn't all being done in silos. So first things first is, you know, you don't need a lot of money to do this. What you need is you need people with passion and energy who can build relationships and are willing to work together. And that's been one of the really big things we've discovered through doing this work. Having said that, you do need a little bit of money and you need commitment from your senior leadership. So you need to get people in the room from the local authority, from the CCG and from the providers, including the care homes, and at the start have those conversations about how you work together to deliver this. They're the things that really we've seen make a difference.
And what are the barriers that you're hearing from people that make it hard across the vanguards? What are the issues that they're struggling with in common?
I think one of the biggest challenges is there's so much going on at the moment. You know, it's tough out there, isn't it? It's tough out there if you're working in a care home. It's tough out there if you're working in the NHS. It's tough if you're working in a local authority. So you've got to be realistic about what you can commit to and what you can do. I think there's always a challenge about getting people to think about this as being important, because it can often be seen as a really small thing. But, you know, the first day I went to Sutton Mary there said to me, you know, we've got 1,000 beds in our care homes. If we had a 1,000-bed hospital, we'd spend all our time talking about it. But how often do we actually talk about those 1,000 beds in our care homes? I think it's about how do you get people to realise this isn't just about a few care homes and a couple of people who need support. This is about some of the most vulnerable people in our local areas who, with a small amount of resource and work, you can do some amazing things by it. It's also really understanding that the care homes themselves are an amazing resource to the NHS. How do you get those people to come together and realise that by working together in a coordinated way, you can deliver a much bigger benefit than if you're just looking at something as simple as, let's think about how we put together a service to support people to stop going into hospital, which is kind of where some of this started, really.
Okay, so we've got a question now that some areas report that NHS community services are commissioned to only go into residential homes, not nursing homes. Have you come across this? And a question both for you, but then we could also hopefully get Leslie back on how are they overcoming those barriers about that commissioning kind of divide?
So I think you have to be realistic. I mean, a lot of the time, people will say things like there's a lot of myth out there about what you can and can't do and what you should or shouldn't do. And you know, one of the things we've talked about in the programme is that people in care homes, that's their home. This isn't somewhere they've gone to that's different. If these people were at home, we wouldn't be having a conversation about whether or not people go in to support them, because they have a right to free at point of delivery NHS services. And I think it's about understanding that the support you would look for from community services going into a residential or nursing home is no different from the support you would look for when they're going into their own home. And I think it's about starting to help people understand that in order to provide the care people need, this isn't about the setting they're in, it's about how you bring those services together to deliver better care. People have started to look in the vanguards around making sure that their contracts don't have perverse incentives within them, but actually a lot of the time people use that as an excuse when it's not really a real thing. You know, we see similar things being said about what you can and can't do with information governance, what the regulators through CTC will or won't let you do. When you really break that down and try to understand what's happening, you realise the amount of myth that's out there and that these things aren't as real as people think. And I think it is about, if you put those people into a conversation together, and what we've found in the vanguards is by having the conversations between a care home and the community services. They can start to understand how they can work together and the support they can give each other, but also the things that they need rather than the things that they don't need. So it's not about going in and doing everything or doing to them, but it's about working with them to add the services that they can't reasonably provide to their residents.
I think that's fine. But has that come up as an issue during the work, or do you think it is about a mindset difference?
I think it's come up as an issue, but I think people have quite easily got beyond it when they try to then think about what are we trying to achieve. I think it's one of those things which, when we look to spread wider to a greater number of areas, it's one of the big myths we have to bust. But it's also, contingent on commissioners really understanding that their responsibilities are to their whole population, not just a subset of the population. So if a commissioner is actually, driving their contracts to do that and to not provide care in all settings, it's something that they need to do as a commissioner, to ask themselves about the questions and the work they're doing with their providers.
Great. So anything more from Twitter or chat box here?
Well, we've just had a question come in from Ruth Twiggins. Are there any examples of care homes being able to call on intensive immediate support to keep a resident in the care home and avoid an admission? The obvious best example of that is the work that they've done in Airedale, a work that they're looking to replicate in Nottingham next year, which is about having a direct video conference which allows you to directly contact the hospital's multidisciplinary team and seek advice and support when you have concerns about a resident. And because it uses video technology, it allows you to actually see that person as well, so that you can build a relationship with the resident rather than just be available on the phone. I think there's some other stuff you can do which is also helpful and simpler. We've seen some really good work in different areas where they're looking at ways in which, when a care home has the need for urgent and emergency advice, whether that's through 999 and the ambulance service or through other local services that are available, such as 111, helping them to understand which is the best bit of the system to navigate. Because for most of it, it's really confusing. Even somebody who's worked in the health service for 20 years, I often don't understand which bit of our emergency care pathway I'm supposed to go to at what time. And so it can be quite frustrating for both residents and care homes when they're trying to get what they need. They end up calling an ambulance because they can't access the services in the way they want. What we found with places where we've introduced enhanced primary care, they've done a lot of work about actually looking at proactive care, because if you work with the care home staff to look at education and development for them, but also build their confidence and build it into part of your weekly work with them, you find that a lot of this work, actually, if you manage it proactively, doesn't then require you to deal with it in an emergency situation. So there's loads of really good examples, which I'm sure the sites are more than happy to share with you.
Great. And we've a question now from John Paul Crofton-Biwer, who's asking about control. So some commissioners do understand about the system, but how do you overcome different organisations fearing giving up control over their part?
So I guess, John, my question would be, which sort of bits worry about control there? What we find is that when people start to sit down and have a conversation without an agenda, they start to discover they have quite a lot in common and that they want to work together because it's in the interest of their service users. Where it becomes difficult is people aren't necessarily able to understand where different parts of the system are coming from. So if you start and go into a room with an idea of what you want, you'll often find that you don't really know how the other part of the system works. And by bringing people together with no agenda and to just have a conversation and just to start to look at what they could do together, we find that's been much better. I don't think people really have as much an issue with control as perhaps people think. I think there's a huge amount of things in the system that make it very hard for you to work together, and that's part of what the Vanguard programme is trying to address.
Okay, and we've got a reply in from Leslie. Audio's not working for her, but she's sent us a message which says, the other thing I would add to William's answer is we must view our community nursing and home care nursing teams as one. For example, when care home nurses can't achieve and maintain competency in some skills such as intravenous antibiotic administration, then community teams must support them, and commissioners and providers need to achieve this together. Thank you very much, Leslie, for being enterprising there, when sometimes the technology doesn't quite work as we want it to. Anything, any comment, William, from Leslie's addition there?
No, I think she's absolutely right. I mean, I think this is about working through in a local area how you do the best for that person and forgetting organisational boundaries. And obviously that there are contract based things that you can and can't do within those. But I think it's about being sensible. When people start coming together as a single team, you really see the benefits. And the one thing that's amazing about the best places I've been to this year, both within the vanguards and elsewhere, is when people have really started to move to a genuine team. If you put people together into teams and they don't really have a good relationship and they don't really work together, most of the evidence suggests that's worse than just leaving them separately. This really does start with good, strong relationships. And then what you want the commissioners to do is to get the commissioning models and the service specs to come together to make that easier for clinical teams and organisational teams to work together rather than harder. And I think that's the real lesson we have. But, you know, in a lot of the places we're going to, we're not seeing people as separate teams. They're all one team trying to do the best thing for that resident.
So we've also had a comment on Twitter from Maike Vanderwijk, and she's very interested in exploring a bit more how local community services can support care homes better. Have we got some thoughts on what seems to be working really well in that space from either William or Leslie?
Leslie, have you got vocal now? It'd be good, I think, for you to pick up that one, but I'm happy to if not.
It doesn't seem to be working, so she's having to type her reply. So maybe you could start and we could see if she's able to do anything additional.
So just repeat to me the question so I get it right.
Sure. So very interested in exploring how local community services can support care homes better. So what's the learning for that group?
So I think it's about firstly understanding who are the population we're trying to serve. So in different settings there will be different populations, whether it's elderly or those with learning disabilities, those with physical disabilities. So it's understanding what are the kind of services you need to go in. If you go to somewhere like Nottingham, they've done a load of work with their dementia team because they realise that the dementia is a huge issue in care homes. Many residents who are in care homes will have dementia, and you've got to really think about how you bring that service to support people in the care home, both working with the existing skills within the care home sector, but also providing the additional support and access to other NHS services for those residents. So it's about how do you think about who are the people they've got and what are the services in need. In the framework, we talk about particularly two areas, end-of-life care and dementia. So there's a whole range of specific things you can do for individual patients, but we know if you're in a care home, you're either in the last years of your life or you're likely to have dementia or some significant cognitive impairment. So it's really important that we're getting the right skills for those services available to support the care homes so that people can stay in their home rather than having to go into our hospitals, because we know that hospitals are a really bad place for older, frail people to go.
Okay, so we're getting a few more questions. Thank you, everybody, for coming through the chat room. The first is from Andrew Dangerfield. Hi, has any work been done around the employment market for care homes? This is something we struggle with significantly locally in Harrogate.
I don't know if this is something maybe Frank or Ian want to pick up from a perspective of the work we've been involved with them around workforce, because there's a huge amount of challenges for the sector around workforce, and there's a lot of really good work that's already been going on for some time nationally to look at different roles and to look at different ways in which you can use the skills you've already got within the sector to help people operate at the top of their skill set and register. And we've also started to work with different sides, think about how do you do shared workforce planning, because traditionally the NHS has very much looked at how do they start to work with their staff, or how many nurses do they need, how many care workers do they need, but there's no point in doing that if it then takes staff away from the social care sector, which then puts additional pressure on the NHS. So for me, you start with sitting down with those providers in your workforce discussions rather than having a conversation about what the NHS needs. We also know that there's a huge amount you can do with training and development. There's really good work that's gone on in lots of the sites, and all the sites are now doing different pieces of work about training and development
bespoke to their area, but also looking at specific things they can do. I know that Leslie's had quite a lot of work they've done in this area that she's put onto it, and they're doing work with their local university and thinking about how do you pick particular topics such as tissue viability, but also infection control and infection prevention falls, because there are certain things that are going to be more prevalent in the care home. It's also worth saying that a lot of the care homes have brilliant care training packages for their staff already. So one of the questions is you've got a care home provider locally who's already delivering great care and training packages for their staff. How do you think about supporting other care homes to get that resource and to perhaps work with them differently? So there's lots you can do in this area. I don't know if Frank or Ian want to add anything.
I'm not sure that they've joined actually yet. If any panellists are there, please do feel free to join. We also have a few other comments back from Leslie about we've learnt a lot about our local workforce through engaging with them over the years, e.g. investing in training and education. So it isn't lost even though the workforce is transient, because they do tend to move between care homes, so skills transfer. And we've also had another question, that's from David Preston. Are there any examples of using those nursing homes to provide localised low-level primary care and or preventative activities such as mobility classes, e.g. for those in receipt of DOM care? And if so, were or are there any issues with CQC registration that were overcome or not? Have you got anybody who would be able to answer that question?
There's not necessarily examples of people doing low-level primary care. I think what you start to see is that, and Leslie again and the team in Newcastle are starting to sort of touch on this, is that actually a lot of the work needs to be thinking about how do you use those community services and nurses differently to support primary care teams. I know that the work that was done in Manchester a number of years ago by Martin Byrne and others, where they were looking again, how do you provide those services to support GPs who need to be there to provide core primary care, but thinking about that additional proactive level. What we're seeing in places like Wakefield, for example, is they're starting to really think about how they use community assets, and we also know in Nottingham they're starting to use different parts of the community to deliver some of these preventative services, rather than it always being delivered through the NHS. I think there's a lot of myths about the CQC registration. Big question in CQC issues are often about who's accountable for that care and how do you really understand what people need to do in terms of making sure that somebody can account for the support and care for that individual. But they don't as such cause huge registration problems, because what you're asking people to do is services that they're often providing already. It's just not necessarily something that's done as a formally commissioned service.
Okay, and thank you, Leslie, that we're getting some comments through from you. We're really grateful for that. So Leslie's saying that the nurses in the care homes get a lot out of working in partnership with the link nurse specialists, and that Northumbria University did a study for the Gateshead Vanguard and made the following recommendations: that competency framework should be developed at 3 levels, and that we should consider introducing a practice educator to facilitate this, and they are doing that starting this week. We've had another question from Georgina Birch to all participants, asking how have different areas managed to get a named GP for the home and set up MDT meetings within the care homes? Got any comments on that, William?
Yeah, so I'm just going to video up and running again. So predominantly people have managed to get named GPs through, I think, one of 3 options. The first is they've used locally commissioned services to commission all GPs to provide an enhanced service to the care home. The second way in which they've done it is, rather than have all GPs do it, they've looked to say get a group of GPs to do it, and to bring those GPs together to provide a service for a number of care homes. Rather than every single GP doing it, you have a group of care homes supported by an individual practice that therefore can provide more bespoke support and also provide an enhanced support to that care home. The third way in which we're starting to see it being done is we've also seen people providing those weekly MDTs, so that you have a range of people coming together as a clinical team to support the care home, doing ward rounds in and around the care home, looking at individual residents who are identified by the care homes needing proactive care or reactive care, and then that linking back through the community teams to the GPs, where the community teams are then aligned to the GP who has a named responsibility for the care home. So there's three real ways in which people have done it. I think we're really testing through at the moment which is the most successful of those. What we're starting to see emerging, I think, and there's limited data on this, so I'm cautious with this, is that by having fewer people support a larger number of care homes appears to work better because they can dedicate the time and energy they need to it. Because often you really do need to take a concerted amount of work. Because if you imagine the kind of the classic NHS triangle we talk about in terms of need, the group of patients here really are on that highest group of residents. I did notice an earlier question from Hilary, I think, as well, which was asking something similar about how we've managed to get in-reach into the care homes and enabling supported discharge. And one of the ways they're doing that in Eastern North Hearts is they've developed a trusted assessor model. So they're currently looking at working with care home staff, being the people who go in and assess the residents for whether or not they're appropriate for a particular home or ready for discharge. And I know some of the work they've done in Newcastle Gateshead, so again, if there's something that Leslie could update on the chat room, they've done some really interesting work about going in and looking at when people's perception of somebody being ready for discharge versus when they're actually ready for discharge when assessed by a specialist. Because a lot of the time what might feel ready for a care home staff member is going to be different from when a hospital thinks they're medically ready to go for discharge. And then linked to that, we've seen some really interesting stuff emerging around using social care providers for intermediate care, where they seem to be really able to rehabilitate and support people to get home by putting them into a social care setting rather than necessarily putting them into a medically focused NHS rehab ward.
Great. And another addition from Leslie about the work in Gateshead is that they've introduced practice-based frailty nurses for older people living with frailty in their own home. And it's a new role, early in evaluation, but early results are showing an 80% reduction in GP call-out and a 50% reduction in hospital admission, which is quite dramatic, and exactly the same principles of care from the primary care team as that delivered by the Enhancing Health in Care Homes Vanguard program. So that sounds really interesting. So there's a few more questions. One from John Paul. How have you managed to coordinate GPs, MDTs, and other services together? The coordination piece. I think you've touched upon some of that, William, in your last answer about the GP linkage. But anything else to add about the coordination?
Obviously, Leslie's the expert on this because they're doing it. But I think it sort of sits in three boxes. The first is about building the relationship. So it's about making sure that your MDT and community terms are really working together closely, but have built a relationship to understand who they are, so they can have conversations rather than it always being something that's done via email or done via a referral. I think the second part of that is then really having opportunities to spend time as clinical teams together. So taking time out after those MDTs or during those MDTs to include the GP within them. And that's where technology can really help, about being flexible in using things such as video technology to ensure that the GP can be there for the parts they need to. The third bit is obviously about sharing records. So how do you really ensure that records are available to be shared between clinical teams? And there's some really interesting work going in each of the areas about how they've managed to ensure through quite simple measures in some cases, and in other areas more complex ways, they're either deploying the clinical care record into the care home through something such as System 1, or delivering opportunities for people to have access to the care records. So when they're making that decision, it's all brought together. If you go down to Sutton, where they've developed their joint intubation group that they call the JIG, it's really interesting how by bringing those people together, they described that they all had a different view of things, but nobody had the 360 view, and it was only by putting them in the room that they got a really rounded idea of what was happening both at an organisational level, but also an individual service user level. And it is by bringing those people together and building those relationships you see a real benefit. What the services then start to describe is once they've built that relationship, actually they can do stuff just as pick up the phone to each other. They know who they are. Really basic stuff is just having the names of the people you're going to talk to in the hospital and the care home can make a massive difference to relationships.
Okay, great. We've got another question from Anna Starling. I was very interested to hear about the collaboration between Principia and Age UK in supporting residents' involvement in the changes and ensuring their voice and opinion is part of the transformation work. It'd be great to hear how other Vanguard sites have engaged residents. Anybody who'd like to pitch in on that one?
So there's all sorts of things going on in this. In Nottingham, they're doing some amazing work with their worry catcher, which is about people going around and talking to residents about very low-level concerns they have, which they won't necessarily get raised as a complaint, but things that they might be worried about, and just really nice things that come out of that, such as by going into one home and talking to different residents, they realise that residents within them are isolated, and what it allowed them to do is bring those gentlemen together so that they would meet and almost get together regularly. So you get some really nice, simple things. I was in Wakefield yesterday, and again, Wakefield doing some really lovely work where they go out and actually work with residents and ask questions, and their evaluation work they've done there is starting to show that the residents have really clear views on what they're doing, but also making sure that they're heard. And I think don't underestimate how much work care homes are already doing in this area. So care homes are really brilliant at advocating for their residents in good and high quality care homes. And so really thinking about how do you use that knowledge of the care homes to really inform some of the work you're doing as well. But there's loads of really good stuff in there, and I'm sure we can share after this some of the case studies we've got around the work that's been going on that I think is very simple and very replicable. And doesn't cost a lot to do, and I think that's one of the really big opportunities in this. This isn't big money, this isn't step changes or paradigm shifts or complex multiple organisational changes. This is about people delivering great joined up care through simple conversations and small ideas that make a really big difference.
Just another addition from Leslie. She's saying that we've worked with one of our hospitals and done a very comprehensive clinical audit looking at those listed as having their discharge delayed, and learned that over 30% shouldn't be on the list as they're not ready to leave. Importantly, some of them have missed their opportune time for leaving, so one of the biggest actions we're planning to take is to get the interface frailty team speaking very early with the primary and community teams as well as the care home teams to make sure that they know the patient in the fullest sense and that hospital is only a tiny part of our patients' lives. Culture change by a simple message. Thanks very much again, Leslie, for contributing as a panellist, even though audio is not letting you join us in that way. We've also had some comments on Twitter, one of them about end of life, which is from Micah. We've introduced an end of life care champion through which their local hospice offers additional bespoke training on end of life. And that was one of the areas that you were talking about earlier, William, wasn't it, about how many people in a care home are end of life or dementia or both. And another one from the same lady, hoping to explore ECHO with local care teams to explore better multidisciplinary working across. Any comments on end of life or the second one there, William?
I think one of the things we were really conscious of when we started this work was that you don't start with a blank sheet of paper. So a lot of the work we're talking about is about applying already existing really high quality evidence-based practice. So, you know, there's brilliant national guidance, there's brilliant work that's been done on end-of-life care before. And what we're encouraging people to do is to ensure that things such as training and development are really in place around that simple systems to stop people going into hospital in the last hours of life particularly are in place, and that's about ensuring people understand what's in their advanced care plans rather than sharing information, you know, retrospectively. So people will often make their end-of-life care plans and their advanced care plans, but then that information isn't available to the ambulance service or isn't available to the care home staff. So it's really about thinking about simple ways. The work that Coordinate My Care has done in London particularly is really impressive in that area, but we've also seen some really good place where care homes have been on the Gold Standards framework, and the work on Gold Line in Airedale as well, which is about ensuring that when somebody gets into the last days, hours of life, there's real support available to them when needed by the care home. So, you know, both for dementia and end-of-life care, this isn't something new. This is about delivering great care, we know, but making sure it's part of a wider system and doesn't sit completely separately to the care homes.
That's terrific. One of the topics that hasn't come up so far is that very important interface between hospital discharge and care home, and also admission into care home, from care homes into hospital. Our local Vanguard in South London, the Sutton Homes of Care Vanguard, has been doing some really interesting work called the Red Bag Project. And I just might invite Rebecca Jarvis to come in and tell us a little bit about that scheme now.
Yeah, happy to. But Kate is on the line, I think, from Sutton. I don't know if we can get Kate Anderson. But I'll just start. So I think, the red bag was shown on the video if people had the opportunity to see that. But basically, it's a really simple concept to kind of smooth the pathways from people going from care homes into hospital. And it does what it says on the tin. It's a red bag. Which includes standardised paperwork that the care homes and the ambulance team and the hospitals are all seeing. And it's an opportunity to include people's personal belongings, which might otherwise get lost. And it's been really successful. I'm sure if Kate is there, she could say a bit more about it. Are you there, Kate, at all to add anything? I think not.
I think just to add to that, Aileen from the Health Innovation Network, a very important principle of the Red Bag is that the care home staff has committed to going into the hospital shortly after a person is admitted. So, I think what quite a few people have been talking about today is joining up those dots. So the hospital learning from the care home staff as well and smoothing that discharge. So the whole Red Bag concept has really joined up all the dots and the complete circle.
And I think they've started to see some really good results as well from their and the swim evaluation data shows that for people with a red bag, they have a shorter length of stay in hospital by, on average, 4 days. And the hospitals are also reporting savings in terms of not having so many belongings going missing that I hadn't realised, but apparently hospitals do have to pay for them to replace things like hearing aids. So there is some really good data emerging, and they're doing a full evaluation early next year.
A message from Jo that she thinks she could maybe get Kate to speak now. That would be fantastic.
Yes, Kate is online. She'll be able to speak.
Okay, welcome. Any other comments you'd have about the Red Bag scheme? Seems to be going down very well. No, we're having difficulty reaching several of our panellists today, but thank you to everybody who's been very enterprising about feeding back through lots of different routes. So, Leslie, we think you might be audible. Do you want to just test that? No.
Hello, hi.
Hello, yes. Hey,
oh my goodness, at last.
I'm so delighted to finally hear your voice.
Oh my goodness, well, as long as you don't say I sound like Ant and Dec, which is what someone just said yesterday.
Not at all. A very feminine Ant and Dec.
Thankfully. Well recovered.
So you've been doing very well typing like a frenzy, but now you can speak. So please, we'd love to hear about the Gateshead experience. Please tell us more.
Okay, I think that if I go right back to 2008, I can remember very clearly one of our GPs in the days of practice-based commissioning. I was working as a provider in community services at a time, and he said we need to think of a way of how we could prevent some avoidable hospital admissions for people that live in care homes. And I can remember very clearly thinking, oh, I know how to do that. It's just CGA. Now, very, very naive that was. But for me now, we started off with the clinical evidence, and staying with it has helped us get to where we are today. And we talk about the care home vanguard and the EHCH. For me, the most important letter there is that H, because that stands for health. And then that flips it straight back to the whole thing that we know about clinical evidence is a comprehensive assessment works and a whole person approach works. And when you think about the whole person, older people living with frailty, those that live in care homes, a significant number have some level of cognitive impairment, then that reminds you to involve their patients and their families and find out all about their whole lives. Then that stretches your thoughts even further to pre-care home admission, and it lets you think about what you could do much way down the triangle of need before people are very frail and living with frailty to such an extent that they need to live in care homes, and it's just become so massive, and the learning has been incredible. It's really difficult to put it into 2 or 3 sentences, but I have been listening carefully to all that William has said, and I've been listening very carefully to the questions as well, and I think that we have talked about older people that are living their lives as independently as probably most of us are, right through to those that have severe dementia, and we've even touched upon end-of-life care as well. That's just what the Enhanced Health for Care Home programme has taught us to do, to think way beyond those that live in care homes, yet still start focusing on health, and all of the other things fall into place. There's such a lot involved. The learning is massive.
Could I put a question that we've just had come in to you, which is the local work sounds brilliant. What's happening in your neck of the woods about STPs picking this up and saying, you know, we'd like to get this framework everywhere? Are you seeing much of that happening, or is the work still locally focused?
Well, it's very early in its conversations, but I think you could use the principles of what's applied through the Enhanced Health and Care Home programme. You could use the principles of that and take it out into the wider community. And one of the things that we talk about is one bed, one outcome. So you could still seek to achieve the same outcomes on the basis that most people have got a bed, and a bed in your own home. You can apply the same principles of care and expect to see the same outcomes thereby. So in terms of locally, our STP is going to focus on intermediate care primarily. So that's a bit pre-care home admission, but it's still people with complex needs. Because let's face it, if you don't have complex needs, you don't need to stop off and use any of the intermediate care services. Intermediate care is the bridge between primary and community and secondary care, and if your needs are straightforward, you just move between those 2 places with relative ease. But if you've got complex needs, then you need to stop off and use some of the services. So that's where we are at. We're going to use the same principles of Enhanced Health for Care Homes. It's a great base for moving out into the wider community, and our first focus will be on intermediate care.
Okay, fantastic. I see that Jane Godden has joined the call. Are you around, Jane?
Yes, I am. Can you hear me?
I hear you lovely and loud and clear, yeah.
Okay, great. Well, I'm from Nottingham City CCG, and we've done a lot of work around joint commissioning and joint contracts with our local authority. So I'm really happy to take any questions on that, or if you'd like me to just say a few words about what we've done, just to describe where we are in Nottingham.
That'd be great, and very timely, because we've just had a question about your
Oh, okay. Right. Well, you know, if we're going back sort of 4 or 5 years ago, we had a significant event here in Nottingham, which we describe as our catastrophe. We had a care home close on a Friday afternoon where they decided that they wanted all the residents out over the weekend, and it was an absolute nightmare, and we had to work really closely with our local authority to achieve that, and with the CQC, and it made us realise that how messy it was having separate contracts within health and social care and 2 lots of quality monitoring visits as well as the CQC, and that it was confusing for everybody. So we decided there must be a better way to do things, and we started working together to see if we could have a single contract with care homes that covered all health and social care commissioning. And after about 18 months of talking and working it out how we were going to do it, we were able to implement our joint contract in April 15. We used the NHS contract, which is quite unusual for local authorities to be using that. They are the lead commissioner on the contract, and the CCG is an associate commissioner, so local authority lead on all the contractual paperwork, pulling together any meetings, contract monitoring meetings with the care homes and so on. And we developed a joint quality monitoring approach whereby the CCG took the lead for all the nursing homes in our area and the local authority lead on the residential homes. We collect information from all of the care homes on a monthly basis, which is a contractual requirement, and all of that information along with the output from the quality monitoring visits is shared at a monthly quality information meeting, which we call our QIF. and through that we've developed a very good joined-up approach to how we manage the quality of care homes in our patch, knowing which homes need the extra support and able to put that extra support in as and when it's needed. At the same time, we've been increasing the support that we provide to care homes through the Dementia Outreach Team, which William mentioned earlier, which is a dedicated team that we have here in Nottingham that provides support to every single care home that has residents with dementia. They provide support and training to the staff, and they also case manage individuals that are NHS funded, so that everyone has that named worker who's responsible for their care. We've also pulled out all of our district nursing from the community teams and created a separate care homes nursing team. So that team is dedicated again to care homes, and within that team they'll have OT resources. We're just about to merge our continence nurses into that team as well, so that there's a specific resource for care homes for continence advice and support, and we're constantly looking at how we can improve and expand that team to ensure that it's a one-stop shop basically for care home support. So that's just a little bit of some of the stuff that we're doing here in Nottingham.
Fantastic, that's great. Also, we've had a reply in from Kate because her audio isn't working either, but she just wanted to add to the red bag conversation. In terms of the red bag, it's important to remember it's a whole systems approach to care. All teams involved in the pathway need to be on board and understand the importance of the pathway. The standardised paperwork is integral to ensure all clinical information baseline about the acute episode is available to teams. This pathway has opened up channels of communication between the care home staff and hospital staff and greatly improved relationships. As Rebecca mentioned, preliminary evaluation has revealed a reduction in length of stay by 4 days for patients with a red bag. So thank you very much, Kate, for joining us in that way. We've also had a question from Ryan, but I'm not quite sure I understand it, so you might need to unpack it a little bit. Would you mind moving my track up a bit? It was about, yes, there are places that have some of the work up in place, follow-up work is that in place, e.g. proactive primary care, meds reviews, end-of-life pathway. Is there a process, stroke order of priority for taking forward other elements of the, is it follow-up work? Is that Ryan, what you're thinking of, or is there something else you've got in mind? But in terms of order...
Do you want me to pick that up, Tara?
Brilliant, yes, that'd be great.
So I think that the question here is, I suppose, about things which, what do you do if you're already doing some of this and you want to start joining it up? And then the second bit of that, I'm guessing, is there an order in which you do it? So is there a way to do this? Do you start with one thing and go to another? I think what we've tried to do within the framework is describe both the timelines they take to do this work, because some things can be done quite quickly, sometimes things take a longer time. But we've also tried to think about, the ordering of, not in terms of importance, but in terms of how you need to do it. So if you can't get primary care support, for example, you can do as many medicines reviews as you want, but if the prescription doesn't get changed, all you've done is identify that person's got drugs they shouldn't be on. So it really is about thinking about this in a joined up way. And what we're trying to encourage with people with the framework is to assess themselves against it and to look at what you've got. Because for most areas, it's going to be about filling in the gaps and joining up the system, not about doing completely new. When we looked at this earlier this year, we found that nearly 40% of the country was covered by people who've already got in place some form of contractual arrangement with their GPs to provide support to care homes and nursing homes. What we're not then clear on is whether or not those people are also providing the MDT support and whether or not people are also providing the end-of-life care support, the training and development, the data and IT. So we want people to really think about how we do that. But as you've heard from the last two examples from, both Nottingham and Sutton, and before that from Newcastle Gateshead, this isn't necessarily about huge complex redesign. It's about very simple ways in which you can start to fill in the gaps between the different parts of your service that already exist. So when I talked to East North Hearts when I went there a while ago, they talked about the fact they'd had medicine reviews in for a while, but because they hadn't yet sorted out the GP work at the time, they couldn't then change the prescriptions and they weren't seeing any of the benefits. As a result of now linking up the GPs who then change the prescription after the medicine reviews, they're now seeing something like 6 to 7 medicine stops per medicine review, which in terms of, a person who's at risk of falls, or a person who's at risk of other challenges such as pressure sores, etc., those risks increase with the more medicines you're putting them on, and so that person's in a safer environment as a result of stopping those medicines, but they're also seeing something like £140 saved per resident. Now, it doesn't sound like a lot of money when you talk about £140, but if you were to do that across the whole country for every care home resident, you're talking about something in the region of £50 to £75 million. So it's a significant human and financial benefit in doing that. But it was about joining up the different bits of what they were doing. So I think what we would urge people to do is to really start with, what have you got in place at the moment? What have you got that you could tweak and change, but also what fundamentally needs to be changed or to be newly commissioned? And that's what we're trying to encourage people to do. I don't think there's an order you can do it in that works. My advice to most areas, and I think what we've seen with the vanguards, is start with people who are willing to work with you. So if you've got 10, 12 people who really care about this in your local area, get them together, get them working together, and get them coming up with brilliant solutions together. And that's what was at the heart of the work that they've done in all of our areas. So, you know, in Nottingham, they used the issue of closing a care home where people said, we don't want to go through that again. The red bag work was about putting people in a room together to come up with a solution to a problem that they all were identifying collectively. This isn't about doing lots and lots of complex things. It's about getting people who care to come together and work together.
So on that note, thank you very much to our panellists, Leslie, Kate, Jane and William. We've managed to answer all the questions that we got today. So if you could just take a moment to do the final poll. How much do you feel you know about care home vanguards? The same poll we did at the beginning. Click on the interactive pen on the left and put a blob for where you feel you are at the moment. Okay, I'll give that a moment or two for a few more people to join. We've got 50 participants and we haven't got 50 dots. Well, some people feeling quite emphatic about their knowledge this time. Okay, that's great. We want to finish on time. So just a few final things. Do please complete the evaluation email. We hope you enjoyed today. We didn't quite have the group that we expected to have today, and many thanks to panelists who have dealt with adversity to get here today. Very plucky, and we admire your persistence. Well done. Any questions at all, do send them to the Care Models team, and do remember to tweet #FutureNHS. Thanks very much for joining us. Hope you have a great weekend. Bye.
Same to you. Thank you. Bye-bye.
Thank you. Bye.